Now we move to fetal demise. Have you ever seen a funeral with a small casket like this? These are tragic affairs. This is St. Peter's Church in St. George, Bermuda. This church was originally built in 1612. And when I went behind the church into the courtyard, this is what I found. Here's a grave marker, and here is a little grave marker. Either fetal demise or a neonatal demise. And here again you can see these little tiny grave markers. It's always a tragedy when you lose a fetus. And here we have a birth announcement that was sent out. It's not pink and blue with flowers and with butterflies. You have the footprint of a fetus that did not survive. Here we have footprints also. Now, why would anybody send out a birth announcement? In a twinkling of an eye, this little one came into our hearts and touched our lives forever. Dear friend, acknowledgement of our baby's short life may be upsetting to you. You may think the less said, the better. And isn't that how we often think? We feel like if we don't say anything, then we don't need to. Until now, we didn't know how important it would be for us to tell you of our baby, even though our baby died. You can help us through this difficult time by letting us talk about our sorrow when we feel the need, allowing us to cry when we want, and don't pretend everything is okay. This birth announcement was from an obstetrician who lost her baby. Now, if people didn't know what happened, what would be the first question they would ask when they see her? How's your baby? I think this was a very smart thing to do, to let people know what would be the appropriate things to say when they see. It will take time, but with your support, we will make it. Here's our case. A 28-year-old multigravid at 33 weeks gestation comes to the office stating she has not felt her baby move for 24 hours. After 20 weeks, the most This is a way in which you can help lubrication if you have a patient who has decreased estrogen or inability for pelvic congestion. KY brand warming liquid. And there are many other preparations with that. RH disease, fetal aneuploidy, we've talked about this, trisomy 13, trisomy 18, Turner syndrome, or a fetal infection. Listeria is a good example of a fetal infection, or rubella, cytomegalovirus, herpes, your torch infections. If DIC is present, and remember DIC is a result of gradual release of tissue thromboplastin from the prolonged retention of a dead fetus, we need to do immediate delivery because this is a life-threatening situation. The laboratory test will show a falling platelet count, less than 100 to 150,000. Fibrinogen, which should be elevated in pregnancy, is decreased. Remember, all of the plasma proteins go up with the exception of albumin. D-dimer is positive. Your prothrombin time and partial thromboplastin time are prolonged. That would be findings with DIC. Immediate delivery. This is not a time when you say to the patient, now, Mrs. Jones, let me explain to you what the options are. We could do this or we could do this. No, this is one that requires emergency, rapid delivery. If there is no DIC, then we need to see, is the mother psychologically ready? We need to not only allow her to experience the grief response, but we need to enhance it because unless she deals with it and makes it real, it's going to take her a long time to recover. If she wants to just wait and let nature take its course, we want to do serial DIC labs, platelet count, fibrinogen, fibrin split products, D-dimer, PT-PTT. The delivery mode. If it is less than 20 weeks, normal anatomy, no autopsy needed, a D&E would be appropriate. If she is over 20 weeks or any gestational age where we need an autopsy because of an anatomic abnormality, then we need to induce labor with prostaglandin. When the baby is delivered, we encourage the mom to see the baby, to hold the baby, to name it, to bury it. Why? We want to bring about closure and to help her bring about closure. Otherwise, she won't deal with it adequately. We encourage her to talk about it. How do you talk about the fetus if it has no name? You call it it. We encourage crying. In fact, it is troublesome for me if we had a fetal demise and there's no emotion because she probably hasn't really even started to deal with it yet. Always we want to identify the cause. Is there going to be a recurrence rate which is identifiable? If there is an anatomic abnormality, let's get an autopsy. If there is a concern about chromosomes, get those. And even if the fetus is dead, you can take connective tissue from the thigh and from of the other areas and get chromosomes. Cultures if there's a fever. Total body X-ray if there is any suggestion of dwarfism. And the Kleihauer-Betke test can be helpful to identify if there is a fetal-maternal bleed. This is a triploidy fetus. Already showed you this one. And here, this baby, or this fetus, was beautiful in the eyes of the parents. They had appropriate grief, and they dealt with this as they should. Here is another triploidy fetus. And you can see the death has occurred in utero. This is your Kleihauer-Betke test. Can you see this is a peripheral smear and there are fetal cells which are darker staining and are larger in size. Do you see them? Let me help you. These are fetal cells. And by counting the number of fetal cells on a high-powered field, you can get a feel for how many milliliters of fetal blood are in the maternal circulation. Okay, let's look at some images of fetal demises. Some of these are not pretty, but they are the reality. And it's important to try to identify the cause if we can. Notice on this fetus, we have a cystic hygroma. Probably this is going to be a 45X. This is an unfortunate and tragic case. These are 19-week IVF twins. This was a surrogate mom who ruptured a membrane, spontaneous premature rupture of membranes at 19 weeks, went into labor, prolapsed the umbilical cord, too early to survive, and delivered. Here we have the viscera are outside of the abdominal cavity. And notice the rocker bottom feet here. This is called limb-body wall complex with marked angulation of the spine, and notice the feet. The big toes, the great toe, instead of being medial, is lateral, and the viscera are extracorporeal. This is evidence of a prolonged demise. The skin is already sloughing off. This is where you need to be concerned with DIC. This is another one, trisomy 18, and notice the clenched fist. This is somewhat of an unusual case. There are no eyes which were present on this fetus. Totally unexpected. This is the trisomy 18 that we looked at before. Notice the clenched fist. This picture shows the angulation of the spine. Normally, the ligaments will maintain their turgor, and you don't have this sharp angulation. But the longer the death has occurred, the more you have destruction of the tissues, and you have these abnormal shapes. On ultrasound, you will see this angulation of the fetal spine. This is what we call fetal hydrops. This may be from an infection. It could be because of Rh isoimmunization, many different causes. Here's another hydropic fetus, the large distended abdomen. There we have a mermaid syndrome, also known as cyrinomelia, and you can see there is fusion of the lower extremities. This is unusual. This is called amniotic band syndrome, and what you find here is malformations which follow no anatomic sequence whatsoever. And what happens here is early in pregnancy, we have collapse of the amnion, which becomes sticky, which adheres to various places on the fetus and prevents the normal development. Notice this large stoma, which involves the mouth and the nose. Notice the fingers are amputated because of the sticky amniotic bands, which prevents the normal formation. Whenever you have abnormalities that follow no anatomic sequence, you need to think of amniotic band syndrome. This one involves the development of the cranium. If you have short limbs, you need to think about osteogenesis imperfecta, and there are many different kinds of it. This is a kind of dwarfism. This is a osteogenesis imperfecta type 2, and you can see how helpful a total body X-ray is of this. This is thanatophoric dwarfism, and there are dozens of different etiologies of dwarfism. Notice there is abbreviated small proximal and distal upper and lower extremities. This is a lethal condition. Another fetus with thanatophoric dwarfism. Notice the short limbs. This is a markedly hydropic fetus, and this is with a fetal demise from a twin-twin transfusion. This fetus became so anemic that it went into high output cardiac failure and died. Its co-twin survived, however. Marked hydrops. Here we have another fetus with severe abnormalities. And this one has essentially no limbs at all, just a head and the body. Here's an example of a test question from the USMLE. Most fetal demises which recur from an infection occur because you have a villitis in the villi that prevents exchange of oxygen and blood gases. In the case of parvovirus B19, there is an unusual pathophysiology. Parvovirus B19 is sometimes called slap cheek. What happens here is the red blood cell precursors in the bone marrow become destroyed. The fetus becomes anemic and goes into high cardiac output failure and demise. So one of the treatments for this is intrauterine transfusion if you find it early enough. Remember, parvovirus B19, fetal demise because of red blood cell precursor destruction. There was a test question on the USMLE, what is the cause of coagulopathy with fetal demise? And we already talked about this. Release of tissue thromboplastin into the peripheral circulation, which sets up the coagulation cascade, and we have DIC. How long does it take after fetal death for DIC to develop? And usually we're looking at 2 to 4 weeks. So this is not an immediate change at all. This is a case which you should not have a knee-jerk response to. Fetal demise, 34 weeks, fetus is footling breech. How are we going to deliver this baby? Now, normally we think when you have a preterm footling breech, you're going to do a cesarean, right? Why do we do a cesarean? Because we're concerned that the body will come through, but the head will get stuck. So, the head gets stuck. What if it takes an hour or 2 to deliver the head? This should be a vaginal delivery. Certainly not a cesarean delivery. Don't pull too hard, however, because if you do, you may pull the head off. And here you can see someone who's been pulling on this body and the neck is stretched. Give it time and it will deliver vaginally. But don't do a cesarean for a dead fetus. The risks are not worth it. Fetal demise is diagnosed at 34 weeks gestation. Platelet count is 70,000. Fibrinogen is 120. What's a normal platelet count? Over 150. So we have thrombocytopenia. Normal fibrinogen in pregnancy should be 400, 450, and it's 120. This is clear evidence of DIC. You got to deliver this fetus ASAP. Induce labor, ideally as soon as you can. Now, you don't need to give a platelet transfusion if we're going to have a vaginal delivery, unless the platelets are less than 20,000. And if you're going to do a cesarean, which you really need to avoid, you would want to wait until the platelets are below 50,000. But clearly, this is not time for waiting. This is time for action. There is actually a National Stillbirth Society that is trying to stop and prevent stillbirths, and I think that's certainly a noble cause. All right, let's just review what we've said. The diagnosis of fetal demise by ultrasound. If DIC is present, less than 20 weeks, DNE, over 20 weeks, induced labor with prostaglandin. If the mother isn't psychologically ready, we will follow with weekly DIC panels. If she is ready to deliver, then we ask, is there a fetal anomaly? If there is a fetal anomaly, regardless of gestational age, induced labor with prostaglandin. If there is no fetal anomaly, less than 20 weeks DNE, over 20 weeks induced labor with prostaglandin E2. And always we'd like to identify the etiology. Most of the time we can't find it, but an autopsy would be helpful. And I have many patients who say, when you ask them an autopsy, oh, the baby has suffered enough already, I don't want to have an autopsy. And then 6 months later they come back and they say, by the way, did you find out why it happened? Well, the best time to find out is to do an autopsy immediately. So we encourage autopsy on all cases. And that's the end of fetal demise.